corniculate on top of the arytenoid. So if they have to go down into the bronchi, they usually will spray an anesthetic. And this is usually a tube that's passed through the nose. To have the video that I'd like to show, the guy is volunteering to have it done, and he's sitting in the bed while they're going down through and everything. But now I have to sign in my age for some reason and show them prove that I'm old enough to look at it, and I don't have a password or whatever for YouTube, so I looked at it a little bit differently. So we're moving down to the top of the larynx. Let's move this through here. On the other one with Tom's, you actually can see the nasal hairs as you go down into the, this is the one I want. Here we go. As you go down into the, through the nasal conchi. So this would be the epiglottis here. There's the cuneiforms. That would be the bump created by the cuneiform. And right here would be the corniculate. All right, so now let's look at something that sounds good.
They're joining in.
That's the wrong costume. I don't want that one. So let me go back to the slide here.
Try to decrease tension on people. That's one area that we'll look at. Okay. Now, why don't you just count to 10 for them so they can see what? Yep.
No, we're not going to go down here. Maybe we'll all get together. Go down here. See the nasal concha? I don't know why they volunteered for this. So you can see the epiglottis a little bit better on this one. So this one's got some damage. You can close your eyes. So to actually have a tube down your throat and singing while that's going on, and be in tune. All right, so all of these muscles are innervated by the vagus nerve. So vagus nerve we know for heart rate. All right, vagus nerve is going to innervate the smooth muscles of the lungs, the bronchi. It's going to go into the abdominal cavity and do all of our abdominal organs all the way over, stopping about where the descending colon starts. But it also does skeletal muscle, okay? And so coming out of the jugular foramen, cranial nerves 9, 10, and 11. And this is 10. It's going to travel down with the internal jugular vein and the internal carotid artery and go down into the thoracic cavity. However, in the neck region, about the level of the jaw, it gives off a branch known as the superior laryngeal nerve. So this is vagus. And this is superior. Laryngeal nerve. All right? So if I ask you to identify a particular branch of this, if you just say vagus, you'll get at least half a point, okay, out of the 2 points. Because these are all branches of vagus. And then superior laryngeal nerve divides into internal and external laryngeal nerves. Internal laryngeal nerve is sensory only, and external laryngeal nerve is motor only. So internal laryngeal nerve is sensory to the region of the larynx above the vocal cords, or I should say from, and the true vocal cords. I asked you to say that. All right? And external laryngeal is motor to one muscle, and that is the cricothyroid muscle, the lateral aspect of the larynx. The one that increases the pitch, raises the pitch. Okay? So internal laryngeal pierces that thyrohyoid ligament that I drew for you between the thyroid cartilage and the hyoid bone. And external laryngeal stays external and comes to the cricothyroid, this muscle right here. Okay, that's innervated by the external laryngeal nerve. The rest of vagus goes down into the thoracic cavity, gives off fibers to the heart, and goes on down. But just inside the thoracic cavity, so much farther than I've drawn here, but it would be down there close to the board, it gives off a branch that comes back up. And we have that small laryngeal model will show the external laryngeal nerve, but this is the only one we have that shows the recurrent. So it comes back up from the thoracic cavity and travels along the posterior surface of the trachea to reach the larynx. Okay? And that's the recurrent laryngeal nerve. Recurrent because it's recurring back in the neck. We see it again back in the neck. So it actually goes down into the thoracic cavity. And then this would be the recurrent, and this one is both sensory and motor. So as you can probably guess, it's sensory to the region of the vocal cords and below, or sensory from. And it's motor to all the rest of the muscles. So all the other muscles I put up on the board except cricothyroid, all right? Motor to all other laryngeal muscles except cricothyroid. Bless you. Now on the right side of the chest, it curves down into the thoracic cavity, and once it's below the subclavian vein and artery, it curves back up and goes over it and curves up behind it and comes back up to the neck. On the left side, it does that around, remember the subclavian is not going to start till way over here, so it does that curving around the arch of the aorta. So subclavian on the right side, arch of the aorta on the left. And in fact, it can indicate or it changes in its effectiveness, and it can be a symptom of an aortic aneurysm. So I told the class last night, about 20 years ago, one of our lab techs, mom, I mean, she's no longer, 20 years ago she was a lab tech, she retired, and her mom had a 10-centimeter balloon aortic aneurysm in the arch of the aorta. 10 centimeters is a little less than 5 inches. You divide by 2.54. A little less than 5 inches, around 4. And as the aneurysm opens up, it's going to stretch the recurrent laryngeal nerve. And that shows up as hoarseness. So something happening in the chest can cause hoarseness in the larynx, all right? So an extended hoarseness without signs of inflammation of the vocal cords should cause someone, a physician, to look for other changes that are going to be affecting the recurrent laryngeal nerve. Those are a bit of a distance from each other, not something that everybody would normally think of. So this is not a question to answer, but as far as your scantrons are concerned, because we're done with those. But so here you can see number 1 is the superior laryngeal nerve. All right. Number 4 is external. Number 3 is internal. You can see it piercing the thyroid ligament. This one's coming to cricothyroid, and here's the recurrent laryngeal. Okay, coming up from the thoracic cavity. So sensory innervation to the superior portion of the larynx would be 3, the internal laryngeal. Motor innervation to posterior cricoid arytenoid, and in sensory innervation B and C would both be 6, because this one is providing motor innervation to cricothyroid. Okay, so any other muscle that's listed besides cricothyroid is going to be the recurrent laryngeal nerve, or motor innervation. All right, so now we're ready to look at the trachea. Yes.
So when you're talking about vocal cords, are we going to go over them? Because you keep saying true versus an I.
All right, so let me diagram it on the board. Okay. The diagram I showed you, and the model I showed you, probably didn't give a clear enough view. Take a picture of this, because I'm going to erase it. Need it? Got it? Okay. So remember I said that the thyroid cartilage, we have the vocal cords attached to the 2 vocal cords, and they also attach to the arytenoids. All right. So we have 2 sets of vocal ligaments, what are called vocal ligaments. Both of them pass between the thyroid cartilage and the arytenoid. We look at them from an anterior view. Here would be our vestibular fold and our ventricular fold. Make it balanced here. So in the vestibular fold would be the false or vestibular ligaments. Okay, that would be these. I'll make these a different color so you can tell. In the ventricular fold would be the true. All right? So these are vestibular or false, meaning they do not create a sound when they vibrate. They don't really vibrate. The true or ventricular ones, when they vibrate, create a sound. All right? So these are the true or ventricular. The ligament is the actual band of collagen fibers. The fold includes any muscles and mucous membrane over them. So our vocalis muscle, is found over and around the true vocal cord. That's what we said pulls the thyroid cartilage and the arytenoid cartilage back together and lowers the pitch of the voice. So you can see that the vestibular folds don't extend to the midline quite as far. They're thought to provide some deflection of debris coming down. I don't know how functional that is, but they're supposed to be protective. The theory is that they're protective structures for the actual vocal ligaments. Okay? So we go back to that image of the small larynx model that I showed you. So this would be where we find the vestibular ligament. This would be the false vocal fold that doesn't vibrate and create sound, and this would be the true that does. So if we put them together like this, and you look down inside, you would see the superior ones are more lateral and the inferior ones are more medial. Okay? Well, that model that I have shown up there is where I think it is. This one right here, okay? And this shows the internal laryngeal nerve, but not the external. So when you look inside, you can't see very well, but this is what you're seeing on that previous one, okay? So this upper fold there would contain the false vocal ligament that doesn't create sound, and that lower one that's painted white on the top of it contains the true vocal cords. So when we talk about cord, specifically we're talking about the ligament. Cord and ligament can be interchangeable. Fold is all the tissues that cover it that you actually see when you look inside, because you're not going to see the actual ligaments themselves without other membranes over them. Does that answer your question, or do you think it needs more complicated?
It helped a little bit.
Okay. So the true vocal ligaments are what we actually control for the
And is it in
modulation.
The ones that are more medial?
Yes.
Okay.
They actually come together and be.
The little white things.
Yeah, these don't. Yeah.
Okay.
Yeah.
Okay, that makes sense.
So what I was trying to draw was this picture right here. Okay? You want to go back to that in your PowerPoint. All right. So now we're going to start with the lower respiratory pathway. And I'm going to focus on histology here. Your quiz for Thursday doesn't cover any of this material. All right? Because this is going to focus on histology. So this material would be on the next quiz, which I do this next week. So we have this model of the lung, and we're not going to talk about lung itself tonight with the lobes and stuff. We'll talk about that on Thursday. On Thursday, we also are doing a sheep pluck dissection. Sheep pluck dissection is optional. All right. So what we do with the sheep pluck is the lungs and trachea and heart. A little bit of pericarp with a little bit of diaphragm. Actually, we tend to get more of the parietal pericardium with the sheep pluck than we do when we actually get the sheep heart. So you'll see more of that, probably even superior vena cava and all that stuff that we didn't see when we ordered the hearts. It even comes with liver and gallbladder. Okay? Although depending on how long it's been out, the bile often has leaked out. Sometimes it hasn't. So what we're going to do is the tracheus segment's probably about that long, and the lab tech set it up with a hollow glass tube that's sterilized. I don't know why the sheep's dead, and I no longer put my mouth on it. But we used to. It goes down inside the trachea. We clamp it with a metal clamp and saran wrap around it so to keep it air from leaking. And then hopefully in removal of the sheep lungs, the butchers haven't lacerated the visceral pleura. And then we have an ambu bag that we attach with more paraffin wrap to that glass tubing and compress it to push forced air into. Thursday we're going to talk about compliance and elasticity and the factors that help to move air in and out of the lungs, pulmonary ventilation. We'll also use another plastic bag and create the pleural cavity. All right. The visceral pleura of the sheep lung, and then the plastic bag will be the parietal pleura. And we'll look at create a situation of pneumotension, thorax, pneumothorax, pneumotension. So I was telling the class last night, when I first started teaching here, we would blow into that tube. And did that several years, until one day I didn't get my mouth fast enough away from the tube, and the elasticity, the recoil of the sheep pluck just blew into my mouth. And so I told the lab techs after that, I'm not doing this ever again. Not ever, 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 ever. And so they started sending the ambu bag. And now they actually send a pump, which is way too noisy, and I don't think it uses enough force, and so I continue to use the ambu bag. If you want to, you may. After we're done with that demo, all right, you guys are welcome to further explore, cut open the trachea, feel the soft tissue behind it, cut into the lungs and follow the bronchi, find the carina or split between the right and left bronchi, dissect the heart, or at least follow it through and whatever you want. So if you want to do that, bring gloves and your goggles, although you can use our ones here, but that's not a required portion. Okay, we just have the one sheet plug. But anybody that wants to work on that, there's usually 3 or 4 students that want to further explore and work with that. When I did this at Sac State, 2008, 2009, the room that we did it in actually had, instead of gas, when you turn on the gas valves, it was air. And every group, we probably had 8 sheet plugs for the students, and so they, instead of blowing into the tube or pumping with an ambu bag, they connected it to the gas valve for air and blew it up, almost literally, with the air, turning the air on and off, okay? We'll actually pop some of the visceral pleura, so you'll see the little bleb, pop the alveoli, so you can see little blebs under the visceral pleura, and talk about that portion of the components on Thursday, alrighty? So, let's erase the board. I'll erase the board, and here we go again. Right where I left it. So remember how for the lymphatic tissues and organs I gave you characteristics that should help you smooth muscle in the capsule, for the spleen, afferent lymphatics, for the lymph nodes, crypts for the tonsils. So on a histological level, whether you see it or whether I describe it in the question, we'll talk about the characteristic components that are present or absent to characterize the different levels of the airways, all right? So we're going to start with trachea. Trachea and primary bronchi. Primary bronchi are the first 2 branches, all right? So the trachea divides into a right primary bronchus and a left, and you can see that the right bronchus is larger in diameter. And it doesn't show up so well here, but it's also slightly more vertical. So if anything is inhaled, as the swallowing goes into the trachea, it's more likely to end up in the right bronchus than the left, okay? So we're going to look at the pattern of cartilage, presence of smooth muscle location, and so on. So here's the trachea. Now, here you can tell this is the trachea because it has the esophagus posterior to it, all right? If the image does not show the esophagus, then you can't tell whether it's the trachea or one of those first 2 primary bronchi, because structurally they're going to look the same in histology, okay? So I'm going to put trachea up here. And primary bronchus. Left or right. So we're going to look at the epithelium that lines the airway, any cartilage if it's present, and any smooth muscle if it's present, all right? So this is going to be posterior aspect, where the esophagus would be, if it was in the image, or the trachea. And I'm not going to change the diameter of the lumen much, because the bronchioles would be microscopic. So we can actually visualize the epithelium. I'm going to have similar lumen, but everything's getting smaller and smaller. Okay, the lumen is the space through which the air is flowing. So the lining of the trachea is continuing as pseudostratified columnar epithelia. And I'm not going to go all the way around. All right? So pseudostratified columnar epithelia. And there are cilia, and there's goblet cells to make the mucus, the purpose of which is to trap any fine particles that made it past your nasal cavities. All right? So the cilia are sweeping this mucus up towards the pharynx for you to swallow or cough it out. So that's the lining epithelium. That's what the air molecules are going to actually be in contact with. And And then we have a C-shaped piece of cartilage that doesn't go all the way around. Posteriorly, there's a gap, all right? This is hyaline cartilage. Those dots are representing chondrocytes and chondroblasts.
That's a tracheal cartilage?
Pardon?
Is that the tracheal?
It's called a tracheal, but the type of tissue is hyaline. All right, so it would be the cartilage that you're seeing here, down the trachea, as well as on the primary bronchi. And as you can see in the model, it doesn't complete the ring in the back, all right? So it's C-shaped for both the trachea and the primary bronchi, the first two branches. To complete the gap in the back, we have smooth muscle. So in the trachea and the primary bronchi, the smooth muscle does not go all the way around the airway. It's not very often that we name smooth muscle, but this is called the trachealis. And a lot of diagrams or a lot of models show it running up and down, but it doesn't, it goes horizontal, okay? The reason we don't have cartilage here is because we have the esophagus in the back for the trachea, not true for the bronchi. And if you were to swallow a large bolus, if you will, of food, you know what it feels like when you swallow a huge pill? It would feel like that every time you swallowed any kind of food, because it would get pressed up against the hard surface of the trachea. Okay? So this it's not going to do anything to change the diameter of the trachea. It's not enough muscle there, but it does allow the esophagus to kind of bulge a bit, and you can feel that on the cheek trachea. Run your finger down and feel the difference between the harder cartilage and the softer. So we have pseudostratified columnar epithelium lining, C-shaped, open in the back, ring of hyaline cartilage, and that ring is closed in by the trachealis muscle, including in the primary bronchi. All right? Okay, so now let's move to the secondary and tertiary. It actually can have 4 levels of branching. Here you can see, you may not have seen it at first, but here you can see cartilage. There's a piece of cartilage, there's another piece of cartilage, and out of view would be another piece. So this cartilage is in pieces. It's like stepping stones, but it goes all the way around the airway, all right? So it's not solid, it's what I call a discontinuous ring. So let's diagram secondary and tertiary bronchi. Now, the epithelia has become simplified. Instead of being pseudostratified now, it's simple columnar. This would be a slightly smaller lumen. To be honest, not like I ever lie every day to you. To be accurate is probably what I should say. The first part of the secondary bronchus is still going to be pseudostratified, all right? But as we move deeper into the secondary, and obviously by the time we get to tertiary, it's going to be simple columnar. So the characteristic epithelia of secondary is simple columnar, okay? Still have goblet cells making mucus and ciliated. Both of these layers will have some cells that have microvilli, but the predominant fold is going to be cilia. All right, for the same purpose, moving the mucus. We don't want that dirty mucus staying in our lungs. In fact, if cilia aren't working, we talked about this with individuals whose flagella of their sperm are missing because of congenital defects, genetic problems, the enzymes to allow the tail of the flagella to beat. Those individuals are more likely to have respiratory infections because they're not getting rid of the dirty mucuses efficiently. All right. Now, for the first time, the smooth muscle is going to go all the way around. All right. We don't name it. So you would think with this increase in the amount of smooth muscle, that this airway would be able to constrict and to dilate. Not much. Because we still have cartilage. And this is what I mean by stepping stones, all right? So we have pieces of cartilage in a ring, so discontinuous, meaning it's not one solid ring, but we have pieces of cartilage all the way around. So there can be some slight change in diameter, but not a lot. So we have this cartilage stiffening the airway, helping to keep it open. Okay? So we change our epithelia, we change the amount of muscle and the amount and appearance of the cartilage. And most of the airways that we can visualize, okay, are going to look like this. Let me go, not certainly as far as surface area is concerned. All right, so here's all the bronchi. So primary is in this C-shaped ring, and then we start seeing pieces. As they get smaller and smaller and smaller. So we'd have the pieces, we'd have complete surrounding of smooth muscle, and we'd have a simple columnar epithelium. All right?
That's a question.
Yeah.
So bronchi and bronchus, same thing? I'm just trying to.
Bronchi is plural,
Okay.
and bronchus is singular.
Is it the same as the simple cuboidal of the bronchus and up there in
On what page?
24?
It's going to transition to simple cuboidal, the very, very end. But yeah, put it in highlights, the characteristic is simple columnar. Which I did emphasize there like I should have. All right, now we move to bronchial, which I already drew a bronchial for you at the very beginning when we were talking about the respiratory bronchial. So this is just showing a close-up view of the simple cuboidal epithelia, all right? But let's move into this area. These are blood vessels, okay? Here's our bronchial. So if you have the flat whiteboard drawn down, we'll draw a bronchial and alveolar duct and alveoli on the next whiteboard. Okay? Alright. All right, the key characteristic, the most easily recognized characteristic of a bronchiole is the fact that they have no cartilage. All right, we'll come back to the significance of that in a moment. So smaller diameter, although much smaller than I'm actually drawing it in relative components. And now we're at simple cuboidal epithelia. Although these don't have goblet cells, they can still make mucus. And they definitely have cilia. And some microvilli. So our epithelia is simple cuboidal. With microvilli. Okay. Smooth muscle all the way around. No cartilage. So what can this airway do that our trachea and bronchi could not? Constrict. All right. So on Thursday, when we look at airflow What were the three factors that regulated peripheral resistance or contributed to peripheral resistance in our blood vessels? Viscosity of the blood, the diameter of the vessel, and the length. All right? Hopefully we don't have too much change in viscosity of the air. We're talking about pollution here if we do. All right? Length. Length usually only changes when we add a breathing tube. All right? So somebody's on a ventilator. Today I was looking through Facebook and it was 16 husbands who went beyond the call of duty, and it showed a picture of a woman who had hurt her back and her bottle of water was this far away, and the husband had taped together 3 or 4 straws so that she could drink from the straw that was way, way far away. So when you try to do that with a narrow diameter tube and a long length, it's hard to breathe, all right? Because your smaller diameter and the increased surface area is going to increase resistance to airflow. But that, again, is usually, unless you're hiding under the water in a river with a straw that you're trying to breathe through so you can stay hidden, that's usually seen only in the medical area. You've got a pump to help push the air through that ventilator tube. So, however, with that in mind then, the bronchiole becomes the most significant airway in controlling airflow. Right? It rhymes with the most significant blood vessel in controlling blood pressure. What was that? The arterial. All right? So the bronchiole is what we'll look at as far as if you have asthma and you're taking salbutamol, that's affecting primarily, this effect is going to be on the bronchioles. All right? Do you remember what the receptor, what we call the receptor for norepinephrine in the heart? Alpha, beta? Beta. Beta 1, beta 2. Beta 1. The lungs is beta 2. Okay? So norepinephrine binding to beta 2 is going to dilate the smooth muscles. It's going to dilate those smooth muscles around the bronchi, but we're just not going to see as much of an effect because of the presence of the cartilage, all right? So we're going to see some major effect here. Acetylcholine, parasympathetic, is going to bind to muscarinic receptors. And just like in the heart, you don't have to know if it's 1, 2, 3, 4, or 5. Although more common is 3, but I don't know the specific one off the top of my head for the airways. Okay? So this then is a bronchiole. It can become a respiratory bronchiole once it has alveoli lebbing out of it. Once we identify a respiratory bronchiole, we can then identify a terminal bronchiole. But without recognizing a respiratory bronchiole, we can't, that's what helps us to define the terminal. So I'm going to draw a longitudinal view of a bronchiole, like I did earlier. Put the smooth muscle, and the smooth muscle we're going to cut in cross section instead of longitudinal section, because it's going around the airway in a circular fashion. All right? Hopefully with that on the board I don't have to label those as well. And then we'll put in an alveolus. That's our first side of the acid chain. So now we're in the respiratory zone, all right? But we go back to a bronchial structure. And maybe we have another alveolus here. Cilia are present even in the areas where I didn't draw it. All right, so we're still in a bronchiole. We still have the simple cuboidal epithelia. We still have the smooth muscle. But once we see our first alveolus, that defines this now as a respiratory bronchial, okay? Now, the bronchial proximal to, and I don't know how many micrometers proximal, but bronchial proximal to the respiratory bronchial, we can now identify as a terminal bronchial. Okay? So on our slide here, here's a bronchial, here's a bronchial, here's an alveolus, and this isn't showing much of that. So let me just see if I can quickly find, I thought I had it on here, but I probably put it on a quiz. This is my favorite one. All right. So, bronchial, alveolus, 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 alveolus. All right. So, respiratory bronchial, bronchial alveoli popping out. This would be terminal. Okay. We still have cuboidal epithelia, simple cuboidal epithelia, but alveoli along the way. And then just proximal to that would be the terminal bronchial. Okay? Yes?
What does acetylcholine do?
Acetylcholine is going to do the opposite. It's going to cause constriction of the muscle and decrease the diameter of the airway. Okay? So our next structure after that is what we see here a bit. There's still some what about the but here, definitely here. And that's called an alveolar duct. All right? So let's imagine that this room is one long hallway of simple squamous epithelia with rooms going off that have wide doorways that we often call them barn doors if you look at house building, okay, or plans for houses and stuff. So wide doorways, a very wide hallway with wide doors going to smaller rooms. At each doorway is a cluster of smooth muscle. But everything else is simple squamous epithelia. That's an alveolar duct. It's the next airway after a bronchial, a respiratory bronchial. Okay? So we're going to draw simple squamous epithelia with alveoli. The alveoli is just this air sac. So our epithelium is simple squamous. But we have these little knots of smooth muscle right here. So you may or may not see that the characteristic is basically a wide diameter with individual alveoli coming off. All right? So that's the alveolar duct. And then just like that, this would be an alveolus. Okay? So the alveolus is the small room. Now, after the alveolar duct, all we have left are alveoli. Okay? But to get from this alveolus or this alveolus to the next one, you have to move, the air has to move through a small pore or opening. So there's no more wide channels. And then to get from this one to another one, you have to move through this pore. Okay? So each of these is an alveolus. Now, there is a term of an air sac, which I've been guilty of using the wrong way, so I quit using it. So an air sac is all the clusters of the alveoli off of an alveolar duct. Okay? But I was using it just as a layman's term for a single alveolus. All right. So see these clusters here? These are air sacs, but we're talking about, here's a single large alveolus enlarged. So here's the normal, not the actual size, but on the model you have this, and then to flip it around, it's showing a larger version of a single alveolus. Okay? So once we get to alveolar duct, our epithelia is simple squamous with little knots of smooth muscle. Once we get to the alveolus, we just have the epithelia. The only smooth muscle is going to be in the not even in capillaries, in the arterioles surrounding that area. So when we talk about gas exchange, we have two simple squamous membranes that the gas has to move across. Simple squamous of the alveolus and the simple squamous of the capillary wall. Okay? So I'm going to finish up lecture with looking at the alveolus. So here's a diagram of what I've been talking about. Terminal bronchial, as soon as we see this, it's a respiratory bronchial. And then we move into the alveolar ducts, and then finally you have just the alveoli clusters. So here's a view of an alveolar duct. See how it's wide? We would have little knots of smooth muscle here, although those are sometimes hard to see. And then the alveolus. So I'm going to leave it on here for a moment. That's what's modeled on that airway that I just showed you. May I raise the board? And we'll just diagram, I will diagram a large alveolus. We have 3 cells to look at here. Okay? Go back. Start over. All right, so most of the surface area, but not most of the cells, most of the surface area of the alveolus is made up of simple squamous epithelia. Okay, and these are identified as type 1 alveolar cell. Simple squamous epithelium. All right? So when we have a capillary, it also is simple squamous epithelia. And it's not going to be right next to where we have a nucleus because that's going to increase distance. And so the capillary epithelial cell nucleus is also going to be not in that space where we have that diffusion. And so those 2 cells, those 2 membranes, epithelia plus the connective tissue in between, make up what we call the respiratory membrane. All right, so we'll talk about that when we talk about external ventilation, the movement of gases across out of the alveoli or into the alveoli. All right, so the most numerous cell, although it doesn't take up as much surface area, is a cell that has lots of lipid droplets. These are the lipid droplets. Okay? And this is known as a type 2 alveolar cell, or a septal cell. And it's this one that you see here. Okay? So it's in between. It's not on top of the simple squamous epithelia. It's in between. This cell synthesizes a lipid known as surfactant. Okay? Surfactant decreases surface tension. What is surface tension? Surface tension is created by the formation of bonds, in this case between two water molecules. All right? So, let me diagram them for you. This is back to basic chemistry, looking at types of bonds. So we talked about bonds in Bio 430. We have ionic bonds and polar and nonpolar covalent bonds and hydrogen bonds. So hydrogen bonds can be found between hydrogen and oxygen, and in the DNA molecules also between hydrogen and nitrogen, and that's what creates the connection between two single DNA strands to create a double helix. So when a cell is undergoing DNA replication, and it has to unzip, those hydrogen bonds are broken, if you recall, by the enzyme helicase, and then they're reformed. So they're pretty weak bonds, all right? So if we have, the reason they exist is hydrogen has one proton and one electron, and oxygen needs two of those electrons to stabilize its own charges. And so they're nonpolar covalent here. They are circulating between, going back and forth between hydrogen and oxygen, and at any given time, they're more likely to be found orbiting around the oxygen, okay? So that makes oxygen have two extra negative charges at any given time, and hydrogen is missing an electron, so its proton provides a positive charge. So if we now bring it into contact with another water molecule, the positive and negative between the hydrogen and oxygen of two separate molecules are attracted to each other because of those charges, and that creates a hydrogen bond. Alrighty? So if you imagine the alveolus as a sandwich baggie that you've washed out, the inside of it is wet, surface tension created by the hydrogen bonds means that those two surfaces, here's one surface that's wet, here's another surface that's wet, hydrogen bonds are going to connect those surfaces together. And if you're going to peel them apart, you have to break those hydrogen bonds. Same thing if you have a wet counter surface and you have a saucer or a plate upside down. Sometimes it's hard to just pick it up. You have to slide it to the edge of the counter or put your fingernails under it. And you can also see this, you have a glass of water, you put your finger on it and then get it wet and then slowly lift your finger up. You can actually lift the surface of the water, okay? So those are all examples of surface tension. What did we say the fetal alveoli was filled with? Serous fluid. It's wet, all right? So that's all we're dealing with when I said that starts to be reabsorbed before the baby is born, about 3 weeks before it's born. A little more squeezed out by vaginal delivery. Then when the baby takes its first breath, it has to break all of those hydrogen bonds, causing all of the alveoli to be collapsed. In the adult, the surface area of all the alveoli in the lungs is approximately equal to half a tennis court. So you can imagine how many millions and quadrillions of hydrogen bonds are in that area, all right? So even if you take 10% of that, and I don't know what the proper proportions are for a newborn's lung, that's a lot of energy to use, even if these are weak bonds, to break and then the baby breathes out. And then when it breathes in again, it has to re-break all those bonds. All right, so for premature infants that have not yet synthesized surfactant, they can often have a failure to thrive as one of the causes is they're using so much energy just to breathe, all right, not to grow, just to breathe. So surfactant, type 2 alveolar cells secrete surfactant starting about a month prior to birth, and it's an oily substance that, once the alveoli are opened up with that first breath, coats the inner surface of the alveoli. So when the baby breathes out, or you and I breathe out, and those alveoli tend to collapse, they're not going to reform those hydrogen bonds, okay? We'll come back to surface tension in just a moment. So, we have another cell that migrates around the surface. This is unusual. It's exposed to air, potentially. It's not in the loose connective tissue. It's not even in the blood like it is in the liver or the spleen. And this is a macrophage. So macrophages have lots of lysosomes any particulate matter that has made its way past the mucus, and it's not stuck to that and gets down into the alveoli, all right? So they're gonna phagocytose it. It's mineral, they can't break it down. And so this oily substance that completely surrounds the lines it is also going to cover over the surface of the macrophage, so it doesn't really dry out, okay? Just exposed to the dryness of the air is not gonna work, so it's really actually covered by the surfactants as well. Now, capillaries in the lungs go carry blood where? Back to the pulmonary veins, which return the blood to the heart. So, studies have shown, several different studies have shown that an individual who's had a heart attack and then subsequently has pneumonia is more likely to have a second heart attack, and it's led to the conclusion that the macrophages go back through the capillaries to the lungs, all right? Taking the bacteria or virus, depending on what the cause was, and damaging the heart tissue. It's already been damaged by the first heart attack, okay? And that's the connection, is those blood vessels between the two surfaces. Now, before we leave this, I want to talk about leading into our first topic on Thursday, which is talking about the lungs. Where would surface tension be helpful? Here we've talked about it being a hindrance to pulmonary ventilation. Where would it be helpful to pulmonary ventilation?
Okay.
Yeah, what do we call this space outside the lung? The pleural cavity. It's a closed space, right? Formed by the visceral pleura and the parietal pleura, and it's filled with a watery fluid, serous fluid. So between those two surfaces, guess what we have? Hydrogen bonds and surface tension. So one of the forces helping to expand the lungs is not just pressure, lower pressure in the thoracic cavity than the atmospheric, but as your ribs are lifted up and your diaphragm is lowered, the lining of those surfaces, the membrane covering those surfaces, is a serous fluid. And as they move out, surface tension pulls the lung out with it. So it's a partial force in helping to inflate the lungs, okay? Not the only, the major force is the atmospheric pressure pushing air in, but it contributes to it, all right? So surface tension inside the alveoli is negative, it's a hindrance, it tends to defeat the purpose and make it more difficult for air to move in. Surface tension between visceral and parietal pleura is helpful, okay? All right, I'd be done. So your quiz on Thursday will be the structures and components that we talked about for nose, including the openings, the nasal conchae, the bones, pharynx, and larynx, down to cricoid cartilage and the muscles associated.